I'm Monsignor Paul Gary, the pastor here at St. Catherine of Siena Parish, and delighted to welcome all of you to this presentation this evening on this very, very important and very timely topic on physician-assisted suicide. And this evening's program is being sponsored by St. Margaret Mary, St. Denis, and St. Timothy's Parish, and so I'm glad to welcome my fellow pastors here this evening as well. Father Myles Sheehan, our guest this evening, is a member of the Society of Jesus. He's actually a provincial for the England Province of Jesuits, and also a medical doctor by training. And so I heard Father Sheehan speak last springtime about this topic, and at that time signed him up to come to us in Norwood here. And I know since then he's had 1,000 requests for all kinds of talks. It's really an engaging topic that we have this evening. So without further ado, please join me in welcoming Father Myles Sheehan.
Thank you very much for coming out tonight. Can you hear me okay? It's really heartwarming to see. When Paul asked me if I would do this, I'd say, yes, but, because when I was in Chicago, people used to sign me up, and I'd drive and I'd show up and they'd have 5 people in the church basement, 3 of whom had just been released too early from the hospital. And so I was like, oh. So it's wonderful to see a bunch of good people here, so thank you. As you may or may not know, ballot question 2 is going to be on the ballot in November, and it's an initiative that will allow physician-assisted suicide in the Commonwealth. What the initiative says is that if 2 physicians decide that you are likely to die within 6 months, they can give you a prescription that you would take on your own to end your life. Now, there are several different things I want to go through in the talk. What I'd like to do is first to just explain a little bit about why the heck this is. Let me tell you a story since my background. I grew up in Marshfield. I mentioned to my dad in around 8th grade I was interested in being a priest. He went, oh, that's nice. So I ended up going to Thayer Academy. I'm not going to let you go to BC High. The Jebbies will get a hold of you. Time goes for college. He goes, you can go anywhere you want that I'll pay for. And he goes, I don't want you to go to a Catholic college. And I go, why? He goes, you're a good kid, you're innocent, they'll grab you, you need to get a little life. So I went to Dartmouth. And then in my 3rd year at Dartmouth, who shows up as the assistant chaplain but a Jesuit priest? And so those are the things. So I did my residency training at the Beth Israel in Boston, entered the Jebbies in 85. 87 to 89, they sent me out to philosophy in Chicago. Came back, and from 89 to 91 did training in geriatrics at Harvard. 91 to 95 I was at the Weston School of Theology, which has now moved over to BC, get ordained, and I worked at the Beth Israel all through that time. Go out to Chicago, and in the course of human events I was the senior associate dean of the medical school. My practice, my specialty was internal medicine and geriatrics, and as a consequence I became very interested in care of the dying. I was listed, and I'm not trying to boast, I was listed as one of the top doctors in Chicago for about 10 years in a line, and I was at something, I go, how many people do you know who have 100% mortality rate, and people think you're a good doctor? And so, I mean, there was an element of truth to that. But I would do a lot of stuff for my kids, I call them the medical students, do a lot of weddings. And so there was one wedding rehearsal, and the back of the church, I see after the rehearsal the bride talking to one of the bridesmaids, and the bridesmaid is like screaming and crying. I go, oh, I'm staying away from that one. And suddenly the groom comes and he goes, Myles, help. Well, the girl had just had what it seemed, she said, it's the worst headache of my life. If I move my head, it's terrible pain. It's what doctors would have called, we thought she had a subarachnoid hemorrhage. I actually threw her in my car, drove her to the emergency room at Loyola, did the stuff, and then I signed the case over and went back to the rehearsal dinner. And I'm there, and a bunch of people are gathered around, and they're medical students, and they go, so what's going on with Becky? That's not her name, but I make it up. I go, well, they did this, and I go, you know, her pupils are flat, the initial CT was negative, they're going to do an LP, and we'll see what goes from there. No matter what, she's going to be admitted. The story is so scary, you know, she needs to be watched and all that. And there's this young guy there, and he's sort of cocky, and he goes, you know, I'm really sick of priests. And I went, yeah, who isn't? Yeah, and I go, well, what's that? He goes, you know, who do you think you are talking this way? Like, you know, because you work at the medical school, you think you're a doctor? And he goes, I'm a surgical resident in orthopedics, and I'm just tired of you throwing around that lingo. who do you think you are? And I go, well, I slept in a Holiday Inn last night. And then I walk back, and all the students say, he's the senior associate dean of the medical school, and he's a doctor. So the guy came down, and he was at my knees. He goes, bless me, Father, for I have sinned. I said, you have. So by way of a funny story, just to let you know, I do have a background. I'm not just talking about stuff that I don't know anything about. I quit practice in medicine. It's up here. I quit practice in medicine in 2009 when I became the provincial and moved back east because I couldn't do everything. It's a little better. There are a couple things to think about when we think about this assisted suicide. And there are a few points that I'm going to make. So for people who want to take a nap, you'll be able to and get the main point. One is, in the Catholic tradition, we are allowed to die. And I think a lot of good people are very afraid that you have to stay on life support forever and all sorts of crazy things like that. I'm going to tell you, in general, you don't. And I'm going to have quotes from the Pope so you don't think it's just something some Jesuits making up, okay? The second part is a lot of people worry about compassion. In fact, somebody at Mass, yesterday, they had a guy from the Society of Propagation of the Faith of the parish I help out on, so I got the Sunday off, and I went to St. Ignatius, and I'm going to talk there tomorrow, and someone said, you know, Father, he goes, I really think the compassionate Christ would really want people to have this option. I go, I think the compassionate Christ would stay with people at the end of life and not give them, you know, a pill to kill them. So I think the other part is to think about what compassion would be. But let's go through these things and talk about some of the things. But really the bottom line I have is, you know, to be a Catholic these days is not something that, as my students would say, appears to be a brilliant choice for success. It's the kind of thing people think you're to the right of Attila the Hun, or that you're mean, or you don't care about stuff, or things like that. I'd argue that our authentic Catholic tradition is a powerful positive force for excellent care in serious illness at the end of life. I think one of the things that happens is some people of good will but less than good IQ, I call them the Catholic Taliban, come on a little too strong, and they confuse some of the church's absolutely accurate teaching at the beginning of life with the end of life, and they forget about our 2,000 years tradition. So I'd like to talk about that over the next 3 or 4 days, so I hope you'll be here for that. So I want to put death in the context of our Catholic faith. I'd like to talk about the Catholic view of the value of life and the need for preparation for death, but also talk a bit about the appropriate sense of the role of medicine, about what doctors can and can't do, to think a little bit about what suffering is about, and also the acceptance of diminishment. Now, here's the point. Many people, why is it that people are, there was a poll a couple weeks ago, 66% of the people who were polled who had an answer, I think a lot of people didn't really know yet, had said that they're going to vote yes on question 2 for assisted suicide. Why would people think that? They didn't wake up in the morning to say, I think I'll be a bad person. They woke up in the morning and they said, you know, I'm scared about what might happen. And this might seem like a good idea if I'm in a terrible situation. What are people afraid of? They're afraid of poor pain control. They're afraid of distressing symptoms that the doctor doesn't pay attention to. They're afraid of a loss of dignity, which is a convoluted thing. And they're also afraid about being a burden on their family. Here's the other part. A lot of people avoid thinking about death and dying. And I think there's something funny with that. So again, doing geriatrics, most of my patients were in their 80s and 90s. I had one patient who made it to 103. With the people who I had taken care of, every now and then I'd talk to somebody in their 90s and I'd go, you know, your labs check out, your exam checks out, you're in good shape. Now I got to ask you a question. If you got really sick, or if you had a terrible accident, what would you want me to do? Would you want me to push hard? What do you think about? And most people would say, well, first off, just shoot me. I go, well, that's very helpful. I'm not going to do that. The second part is I don't want anything. And then I'd explain, you know, I could do stuff for a couple days and we'll see what happens and you might go home. Because this is one of the things that's important to talk to people when they're older, is there's a lot of, a person who is previously healthy but older, a sudden acute illness represents a situation that may well be reversible. So I was extremely aggressive often for the first day or two with people who are sick, and then you got to sense what was going to happen. And I'd say, if things aren't working out, I'm not going to keep on being aggressive. Is that okay? And they go, that's exactly what I want. But about 20% of people say, I don't want to think about it, I don't talk about it. Well, I go, you're 90 years old. Well, I mean, you know, it's got to happen. I tell a story about my dad. He was reading the newspaper, and he goes, "Oh, for crying out loud." That's not what he said, but that's what I'll say here. I have my wife's picture in my back pocket, so I can't say what I was going to say. But he threw the paper down. I go, "Daddy, what's wrong with you?" He goes, "This stupid thing." I go, "Well, what is it?" He said, "I was reading the obituaries." I said, "Are you in it?" He goes, "No, that's not it." And then I said, "Well, what's wrong?" He goes, "James Smith dies unexpectedly at 95. He goes, "Suddenly, yes. Unexpectedly, no." So again, people are funny in this country about not thinking about death and dying. Now, I grew up in another tradition, so I was the caboose. And so my mom was 40 when I was born, Dad was 43. My mom died about 10 years ago, and 2 weeks before she died, I was cleaning her up and fixing her and putting her back in her night clothes and did the bed, and she gives me a big hug and she goes, "Oh, honey, am I glad I had a baby at 40. But again, this sense of, so I grew up in an Irish Catholic family. They're from Charlestown. We moved to the Irish Riviera down in Marshfield. But I mean, wakes were part of life. And I can remember when I was really little, to go to a mass where the priest didn't have black vestments, I go, why aren't they wearing black? You know, everything was then. And that was a little strange too. But my point was that death was part of life. And it was partly from my folks. So there were 7 in my dad's family, and 3 kids died before the age of 2. There were 5 in my mother's family, and her dad died at home, her aunt died at home, her little brother died at home, which was really a tragedy. But people you cared for each other, and you knew that death was part of life. You know, I grew up with the stuff about doing the first Saturdays and thinking about the grace of a happy death. I grew up in a tradition where death was part of life, and it was sad, and you cried, but you were prepared. And it wasn't like this big medical thing. It wasn't sort of crazy the way we get about stuff now. Now let's talk about how things were in the past. And you'll see some of my slides say EPIC. It says Educating Physicians on End-of-Life Care Curriculum, and I did a lot of work with them, and I have permission to use their slides, so I'm just being a good academic and referencing it. About 100 years ago, in the early 1900s, the average life expectancy was about 50. Now, plenty of people lived into their 70s. It was because so many people died before 20, because of the lack of antibiotics, the lack of vaccines, and in a lot of areas, the lack of clean water. My dad grew up in a house where he used to tell me they used to have to go to the bathhouse once a week in Charlestown to take a bath and a shower and stuff like that. He said sometimes even if you weren't dirty, you had to do that once a week, you know? And so infectious disease and accidents were the major cause of death in the absence of antibiotics. Story about the discovery of penicillin in the 1930s. This guy, Alexander Fleming, he wasn't Sir Alexander Fleming, had been working with a mold, penicillin, and he was ready to try it, and a British cop, a bobby, using a straight razor, had gotten a bad cut on his face, and it got a kind of infection from strep, like you get in your throat, but it can get in the skin. It was called erysipelas, and so he had a really bad infection. And he gave the guy a little bit of the penicillin, a little bit each day for 5 days, and the guy got almost all better, but he ran out of penicillin. He died. He died from a bad cut. In 1944, my dad was crossing back and forth on the USS Wakefield, troop transport, and he was a new doctor and the ship's doctor. And so one of the soldiers had ruptured his appendix, and penicillin wouldn't work for that now, but they gave him penicillin. My dad had to collect all the soldiers' urine to boil it down afterwards so they could reuse the penicillin. So again, we're in a different world than we are now. They cleaned it up. It's not that dirty. It's okay. It's just an idea that we've really gotten a different sense of the way things are now. Now, here's another story. It's in the early 1970s. We're in the, I don't know, Tedeschi's or something in Marshfield, and I'm shopping with my dad, and a guy comes up and he goes, "What do you want to be when you grow up?" And I go, "I'd like to be a doctor." He goes, "Well, I want you to be as good a doctor as your dad was." Well, my dad stopped general practice in 1952 and then did some anesthesia. And as I thought about it as I got older, what did Dad have? He had penicillin, he had streptomycin, and he had sulfa drugs. Now what do we have? We can cure a lot of leukemias, Hodgkin's disease. We do miraculous stuff with the heart and all this other stuff. People don't like doctors now. People loved their doctors back when they really couldn't do a hell of a lot. What was the difference? They cared for the person in the context of their family. They provided caring and support even if they couldn't effect a cure. And there were ways in which they could heal even if curing wasn't possible. Now we emphasize science and technology, and there are big changes in how we do stuff. I have nothing against science. I mean, I think it's a good thing. And I think the use of technology done judiciously provides for incredible changes. When I entered the Jesuits in '85, our cemetery out in Weston, most of the guys were dying in their 60s and 70s. We now have a guy who's 102. We have most people die in their 80s and 90s. Things have really changed in my lifetime. I'm 56 now, so I was born in 1956. But with the changes, there's also been a big shift in values in our larger culture. There's a denial of death, there's an emphasis on youth, it's productivity and independence. Again, when Nana got sick, she moved in with us. That doesn't happen that much anymore. And so in some ways, age and family and interdependent caring isn't valued the way it is now. And here's the other stuff. Death has become the enemy. We're going to fight cancer. We're going to beat this disease. Well, you know what? You can do everything you want and try, but you're still going to end up dead. And you might wear every ribbon in the world you want to, but people will still die from cancer. It's part of what it means for us to be animals. Our life is limited. Now, the major reason why life expectancy increased was because of sanitation, but then over the last 3 or 4 decades, it's been by decreasing blood pressure, by taking care of heart stuff, by being able to work a little bit with diabetes, by people not smoking like chimneys the way they used to. But what does that happen? A lot of the things that even when I was in medical school people would die from, they're now chronic illnesses. So in 1982 at the Beth Israel, I saw the first case of AIDS in Massachusetts. That guy, strapping young man. He was dead 6 weeks later. Now people with HIV, they live 20, 30, they can live a normal life expectancy with the medications. And how is it we die? And this is the important part. Less than 10% of us drop dead, get shot, die in an accident, don't wake up in the morning. So that's 10% is sudden and unexpected. About 90% of us, the way we die, it's a more prolonged process. And there are a couple different ways to think about it. One is the stuff where people would have, like, say, a bad cancer. So you get treated, you do well for a number of years, it comes back, and then it's a relatively short time. People recognize that. I think they sort of go, well, it came back and I had a good time, I understand. The part that people aren't good about recognizing, and doctors as well, is that when somebody has like really bad lung disease, really bad emphysema, they're in and out of the hospital. Or they have Alzheimer's disease or another dementia. They're in and out of the hospital. Those ins and outs, we fix them up in the hospital and throw them back out, but we don't pay attention to the fact that they're inexorably sliding downhill. If you ask doctors often, how many patients do you have right now who are dying? And they go, a couple. And they go, how many patients do you have that if you were to look in the newspaper in the next year and see that they had died, would you be surprised? And they go, oh, 20 or 30. And I go, shouldn't you be taking care of those 20 and 30 in a different way than you are from those people who you don't think really have a life-threatening illness? And again, in geriatrics, what I used to look at is when an older person began to fall apart. So it'd be a question, they're losing weight, they broke their hip and didn't bounce back. They would have a stroke and not recover. I would care very hard for that person, but I would limit medical intervention because I go, well, what are you going to do? You just going to torture them? You know, a number of my patients, I used to be able to do house calls because I had a vow of poverty, and so it didn't make any difference. And so a lot of my patients would just refuse to go to the hospital. They'd say, it's foolish there, I'm not going to go there. And they go, you come here and you do the best you can. If it doesn't work out, that's fine. Our health system probably can't afford that kind of personal care. But part of the thing that we're talking now about assisted suicide is we get into stupid situations where you go, well, medicine's the problem, or this is the problem, and I need control over my life. What we really need to think about is how do we have a civilization of love in the midst of the culture of death? And that's one of the things that John Paul talked about. Symptoms and suffering are important, and I think the other part is that people sometimes think that doctors and others don't pay attention. You know, one of the things that can be important is so that these orders called do not resuscitate. In other words, and many physicians have them tattooed across their chest, so that here's the story. If you've been very sick, chances are those resuscitation things you see on TV where they do the paddles and all the other stuff, in an in-hospital resuscitation, how successful do you think those are? If you had 100 of them, how many people do you think would leave the hospital by the front door and not in a box? 10. 10. And of those 10, almost all of them happen in the emergency room or the intensive care unit or in the recovery room. Places where somebody has something sudden that's funny, like an acute heart attack or those other things. People have a pneumonia, people have kidney failure, people have other stuff. You might get their heart started, but they're going to die a few days later. So people don't think about it. And often, doctors they're not encouraged to have the conversation. And this is the other part about our civilization. So that, you know all that crap that they talked about death panels a few years ago? For me to spend an hour with an older person and their family and talk about end-of-life care, it was difficult to bill for that. Now I can bill if I was practicing medicine. That's the crap about death panels. Don't you think a doctor should be able to get paid for that? Yeah. I mean, people do need to make a living. And so that's part of it. But there are things. So people weren't paying attention that death was coming. Many family members thought their family member who was dying was in pain. And so what do we have? We have a bad situation where it's a fertile ground for people who aren't bad people to think that, you know, assisted suicide sounds like a good idea, you know? Heck, the doctors can be problematic, the hospitals are problematic. I don't want to be stuck. I want to be able to control myself. So people say they don't want to die in a machine or in discomfort or be in a burden or die in an institution. A lot of people say they want to die at home, but the problem is there isn't anybody at home anymore to take care of them. You know, that's a whole other thing. 90% of Americans will say it's a family responsibility. However, that family member usually turns out to be a woman in her 30s and 40s who might have to take care of kids, parents, maybe even a grandparent. That woman gets really stressed in the middle. It would be very easy if you were sick in that situation to say, I'm a burden, I'd be better off to leave her alone. You know, I really should get out of the way. There are ways in which it can be better, and I've seen it better. We need to do more. Assisted suicide is not a way to improve the level of care in our Commonwealth. It's a way to say, it's too hard to care, so let's just get it over with. Now, what is death about? I made it a little bleak. Is it about despair? Is it about being terrified? Is it about poor pain and symptom control? Or is it like the 90-year-olds who go, why we don't talk about it? Is it about amnesia? No, we have a more excellent way to think about death as Catholics, as Christians. And that more excellent way is from 1 Corinthians 12:31, the greatest of these is love. You know, the next stuff, you always hear at every wedding. We don't take death out of the context of what we believe. And I think this is an important thing, an important contribution that we as Catholics, who I believe have one of the richest cultures in the world in terms of understanding the meaning of death in the context of our life. So first off, we believe that Jesus Christ suffered, died, rose from the dead. We're called to eternal life. In the face of people who say, I need control and I want to have assisted suicide, there's a very good person, Marcia Angel. She's a former editor of the New England Journal. She's on the radio a lot these days, talking about the compassionate approach. It's always compassionate approach, is to allow assisted suicide. I think she's sincere in that. I don't think she's bad. But I think compassion is found in ways in which we value community, we care for each other. Even when life is declining, we value it. That doesn't mean you have to be a nut and do everything, but we value the people that we love as they face the end of life. But American culture, individual, personal independence at all costs, wealth, success, youth, interdependent caring, the context that our lives have meaning and value that goes beyond whether or not we're pretty anymore, those are things that aren't valued. Our hope isn't limited to this world alone. And so what is it from the beginning? Well, we begin with our faith. A human life is more than our time on this earth, and our dying is how we're born to eternal life. Now, the next few slides, what I'm doing is try to emphasize the point. I used to ask my medical students, so at Loyola, Chicago, and I'm teaching the introductory ethics, and I'd say, true or false? So there'd be 130 kids. I go, true or false? The value of life on earth in the Roman Catholic tradition is absolute or not absolute. How many say absolute? That all raise their hand. They're wrong. This is not something that I made up, okay? Yeah, this crowd's got to know the answer. Who made you? Why did God make you? And to enjoy eternity with him in the next. So what's the goal of our life? Eternal life with God. Why do we honor martyrs? Because our human life, our life on earth, is not an absolute value. If someone comes in here and puts a gun to my head and say, renounce Christ or I'll kill you, well, it depends on the situation. But but there are situations where you are going to die for your faith. If our human life had an absolute value, we wouldn't be honoring these people. That's a point that Pope John Paul II makes. We have a supernatural vocation. The point of our life is to enjoy eternity with God. Now, our life on earth has inestimable but not absolute value. And what the Holy Father said, it's the supernatural calling which highlights the relative character of each individual's earthly life. So that means, our life on earth does not have absolute value. So those people who say you have to do everything at all times if you're a good Catholic, they're full of it. They're wrong. They're just wrong, okay? The Holy Father said life's not an ultimate, but it's a penultimate reality next to ultimate. But it's a sacred reality. So we need to think about death and dying, first from our authentic Catholic tradition, not from the people who mean well but don't know much and are absolutists. Also not from the perspective of folks who say, well, if I can't do what I want to do, then I just want to end my life. The other part we're going to make the mistake, got to be clear, is being Catholic is not about being against things. It's not too shocking that a Roman Catholic priest gets up and say, I'm against violations of the fifth commandment. I was talking to a group of priests a month ago, I go, against violations of the sixth commandment, and they looked at me, and I go, and the fifth as well. But I don't know what was on my mind. But it's important to think about how we build a civilization of love in the midst of a culture of death. And what would that mean? Well, support for the dying and their families. There are ways to do it, and it is being done. To provide spiritual meaning and comfort for people as they face the end of life, to provide a believing community that can show that that person's loved even when they're not able to do all the stuff they want to, where forgiveness is available as well as hope and caring. And here's the part, excellent pain and symptom control. When I went to medical school at Dartmouth, graduated in 1981, I had 4 hours on death and dying. I had 25 hours on parasitic illness. I took care of a lot of people at the end of life. None of them died from worms or anything like that, okay? So I was all set to take care of, Trichiurus trichiura and all these other crazy things, Strongyloides stercoralis. Never saw it, was always looking, but all these people were dying from heart failure and kidney failure and old age. And I didn't know a heck of a lot about how to do with that. So I learned. And really, a lot of what I did academically was to crusade for excellent pain and symptom control, particularly in Catholic hospitals. And I have to say now that Catholic healthcare is actually a leader in the United States in providing excellent palliative care. I'll talk to you more about what that word means. Why don't I do it now and I can just skip the slide. Hospice is a kind of palliative care, okay? So it's like we're talking about dogs. Dogs, all kinds of dogs are palliative care. There are some dogs that are spaniels, okay? Hospice is a kind of palliative care that you use in the last few months of somebody's life. Palliative care can be provided anytime in the context of a serious illness, and it attends to the complete experience of a person when they face a serious illness. So, for example, you have a woman in her early 40s, she's found to have widespread ovarian cancer. She's going to be able to get several good years from aggressive surgery and chemotherapy. She should absolutely do it. But even from the moment of diagnosis, there's other kinds of suffering than physical. She's going to go through the spiritual. And you hear this, why me, God? I was a good Catholic girl. I went to St. Catherine's grade school. I did everything right. I, got married. I didn't mess around. I have 3 kids. That one down the street, always seems to be entertaining the guys from UPS, and she's fine, but I'm dying, and why has this happened? Why me? That's a hard question to answer, and the person has to explore that. To provide assistance, or at least a companion on that journey, is an important part of care. There's also the psychologic stuff. What's going to happen to my kids? There's the issues with the relationship with her husband. After she's had big gynecologic surgery, their relationship will not have the same physical aspect. There are other parts there to also think of. Maybe she had a job. She might not be able to do that anymore. How do you provide for the complete change in meaning and understanding of what constitutes your life when you have a serious illness? Taking care of pain and symptoms is important, but these other things also need to be attended to. And again, at the best medical centers, people are doing that now. What's particularly troublesome about the assisted suicide referendum in Massachusetts is that Boston represents really one of the leaders in the world for medical care. Arguably, some of the care is too technologic, too aggressive, and too much focused on miracle cures. I'm very worried that if assisted suicide becomes an easy option in this Commonwealth, it'll become part of, well, that's what doctors do. And that just doesn't make sense to me. Because I know from my care of older people and from attending at a number of bedsides where people died, that actually was one of the most satisfying parts of my medical practice and called for all the skill and all the knowledge. Because frankly, at home, when you're taking care of somebody's symptoms and you don't have a whole hospital around you, you really got to have a lot of skill and think smart and try some stuff to make people comfortable. And again, to allow somebody who is facing the end of the life to die well with their family around them, man, I felt like that was what I became a doctor for. It was a wonderful thing. And I think we can do so much better. I think we can do so much better. I'm not going to go through all the ethical and religious directives, but part of the reason I'm going to show you some of these official slides is, again, sometimes people who are very frightened by the shifted values in our country and sometimes the conflicts within our church will assume that a priest who is saying you don't have to give absolutely everything all the time is an agent of Satan or something like that. So I want to show you that the things I'm saying are backed up by solid Catholic doctrine. What I want to do is for people who are afraid that I'm making this up, or for people who have the mistaken impression that Jesuits are not good Catholics, and that's absolutely wrong. No, I'm not amused. That's absolutely wrong. I want to show you that this isn't a thing. The Society of Jesus makes no sense without the Roman Catholic Church. And so it's important that anything I teach you is based on that. The ethical and religious directives are a series of guidelines. It's a pamphlet, basically, about 70 pages, that's written to provide understanding of what it means to be a Catholic hospital. And adherence to those allows the bishop to say, yep, the place is a Catholic hospital. Unfortunately, if you read the Boston Globe or the New York Times, there are only 3 sentences. No contraception, no sterilization, no abortions. They never pay attention to anything else in there. So there's a whole part about labor unions. There's a whole chapter on end-of-life care, and I'm going to show you some of those things from that. As a witness to its faith, a Catholic health institution will be a community of respect, love, and support to patients and their families as they face the reality of death. Effective management of pain in all its forms is critical in the appropriate care of the dying. Occasionally I'll run into people who are very religious who say, well, I shouldn't take pain medicine, I should offer it up. I can talk a little bit more about the meaning of pain and suffering, but I think that's crazy, okay? And so I want you to know that these were approved by the bishops, and then the guy in Rome who approved it was somebody called Joseph Ratzinger, that notorious liberal now known as Benedict XVI. Okay, so this is pretty much respected. The task of medicine is to care even when it cannot cure. Physicians and their patients must evaluate the use of technology at their disposal. In other words, it's nonsense to say that you have to do everything. You need to think about the context. Now that's hard when you're scared or you're frightened, and I spent a lot of time, and the point I meant to make was at Loyola we had an extensive curriculum in end-of-life care related to ethics, and they were not unique. I actually thought we had a really good one, but we're not unique in that. So medical students and doctors in particular are much more attentive to this than they were when I was in training. Things are improving. I think allowing assisted suicide is not going to help that improvement of knowledge and care for people as they face the end of life. Reflection on the innate dignity of human life in all its dimensions and on the purpose of medical care is indispensable for formulating a true moral judgment about the use of technology. Only in this way, the two extremes avoided. An insistence on useless or burdensome technology, on the other hand, the withdrawal of technology with the intention of causing death. One of the hardest things about Catholic is it requires that you think. So if someone says, do I have to do X, Y, or Z? You go, it depends. It depends on what are going to be the burdens, what are the benefits. And if you're not going to do it so you deliberately die, that's your goal, there's a problem with that, okay? What about withholding therapy? Although you have to use ordinary means, and that's a whole other thing. But say you have high blood pressure and the pill costs $1 a day. You should take the pill, okay? If, on the other hand, well, here's a perfect example from my mother. 87 years old. She'd been declining. I had moved her out to Chicago to be near me, and I put her in a place called, it was a lovely place, called Resurrection Life Center. She called it Resurrection Death Center, or the GD Orphanage. So, but she also liked it pretty much okay. And so I come in, and she goes, take a look at my leg. And it's all swollen. I go, ooh, you have a blood clot. And then I lift it up, and she has blood clots in both legs. And the next day I send her for an ultrasound, and it goes all the way up into her stomach, into the inferior vena cava. So most likely at that time she had a hidden cancer. And so I said, Mom, you need to go to the hospital, get heparin and to do some other stuff. She goes, I'm not going to the hospital. I go, why? She goes, all doctors are fools. I said, what about Daddy? What about me? She goes, case closed. And then she goes, look, I'm old, I'm frail. I fall, I wet myself. Some nurse is going to be a witch, and at 2 in the morning when I have to pee, won't let me get out of the bed, and I'll try to crawl out of the bed rails, and then I'll slip and fall and break my hip. I don't want to. I said, what do you want? She said, I want you to stay here and hold my hand. Now, she died 2 months after that. At 87, with her last words, I love you, honey, I'll see you soon. Now, did she do something morally wrong to not go to the hospital? For somebody else, if any of you who are healthy said, I have a blood clot and I'm not going to get it taken care of, you're refusing ordinary care, and I'd say that's stupid. She was failing, and she knew something badly was wrong, and she said, no, I'm not going to do it. She decided that the burdens outweighed the benefits. That is an appropriate decision to be made in the Catholic moral tradition. I can't in the abstract tell you about individual decisions because it depends on the lived context, the state of the body. Here's the hard part about being Catholic. You got to think. Common sense is no longer common. And the other part is we live in an age where people feel very strongly and think very weakly. So it's important to use things like reason, understanding, faith, common sense. If you got a good doctor, you got a good priest. The problem is in a lot of these things, both doctors and priests get frightened and give a very, very restrictive answer. Not because they're bad people, but because they don't understand this stuff. What I'm trying to say is we really have a wonderful tradition, and it provides a lot of good opportunities. But we live in a time that's so nutty and polarized. We use the existence of gray cases that's sort of hard to know what to do as an argument to deny black and white, you know? And there are things that are clearly wrong and clearly right, and most of the time that's where it is. What about palliative care? So palliative care is supportive care that can be given from the time a person's diagnosed with a life-threatening illness and neither seeks to hasten nor to extend the life. It provides a variety of different treatment options. As a person is in the last months of life, hospice care will be given, which is purely symptomatic care, which is dedicated to, in the very best sense, making sure that a person has a good death. Here are the things just to say, but patients should be kept free of pain as possible. And medicines capable of alleviating and suppressing pain may be given directly to a dying person, even if this therapy may indirectly shorten the patient's life. Now, for those who are physicians and nurses, pharmacologically, there's been some changes in our thinking. When I was a resident at the Beth Israel, we would get people who would be admitted for terminal care, and they were uncomfortable, and they had good oncologists who had given them a lot of oral pain medicine at home, and they were still in pain. And I would give them morphine, and I'd start with a dinky dose, a couple milligrams, and then I'd come back in an hour and go, how are you? And they go, yeah, I hurt. I give them 4 milligrams. And are there times when after I gave the morphine, the person died? Yes. My intention was on a person who was otherwise dying to relieve their pain and not to kill them. That's completely within the Catholic tradition. It's called the tradition of double effect. One of the other things that's interesting about our culture these days is that over the last 20 years, there's been a tremendous attack on this idea of double effect to say, well, there's no difference. Why didn't you just start off with 100 milligrams and get it over with? Because with 100 milligrams, I'm a killer. If I start with 2, I'm trying to be a healer. And the effect of healing, unfortunately, has the unwanted effect of perhaps hastening somebody's death. A lot of people say, well, that's not a real difference. I think it is. I think it's a real difference. So what are the things to remember? You got to pay attention that medicine is not just for miracle cures, it's about care for the dying. And given that a number of the treatments we do stop people from dying but converts what used to be commonly fatal illnesses into chronic illnesses, so we need to how to provide that care. And that chronic illness doesn't mean you're miserable. It just means that you need a different kind of attention than other people. Effective pain control and relief of suffering is crucial. So here's the other big lie. A number of people think that if you have cancer, you're going to die screaming in pain. If you do, it means your doctor's a jerk and a quack. So I used to, when I moved to Illinois, occasionally get calls. So I got a call one day from a lady in rural Illinois, and she said, can you help me? I said, with what? And so she said, here's the story. I have metastatic breast cancer. It's in my bones. The doctor gives me a prescription for 10 Percocet a week. Now, 10 Percocet, if you're feeling fine, would be more than enough, and you can make a lot of money on the street with it, but that's a whole other story. And he says, I have to be very careful or else I'm going to get hooked. I go, sweetheart, I'd pay for you to go to the Betty Ford Center 5 years from now. That's not going to be a problem. So sometimes doctors were really jerky about that. It's much, much better now, much better. Doctors have learned a lot about how to treat pain. Not as much. There's still a lot of education to be done. But again, it's much better than the dark ages where people would say, oh, I don't want you to get addicted. You told me I have 3 months to live. What do you think I'm going to do? Be, on Blue Hill Avenue selling heroin? I don't think that's going to be happening, okay? What about the value of life in the Catholic tradition? I think this is a wonderful quote that hasn't been seen much. The Holy Father went to a hospice in Vienna in 1998, and he said this: the artificial extension of human life and the hastening of death, although they stem from different principles, conceal the same assumption. The conviction that life and death are realities entrusted to human beings to be disposed of at will. It must be made clear again that life is a gift to be responsibly led in God's sight. What's this saying? It says that the Dr. Kevorkians of the world, or the people who are the physicians who are pushing assisted suicide, they think that they are in control of life. There's also another group of people, and regrettably, it's the good Catholic doctor who went to Boston College and then did this and did that, and I have to do everything for my patient and keep them on life support because I'm not going to allow the death to occur. Both those people have it wrong. The issue is that life belongs to God, and you have to try to make responsible decisions. Most of the time, it's common sense. Sometimes it's confusing. And you do the best you can while making sure that you never say, I want to be killed. I don't want someone to kill me. Okay? You're not allowed to do that. But you can make choices like my mother and say, to hell with the doctors in the hospital. I'm an old lady and I'm falling apart. I'm not going there. Okay? One of the things, a couple things just to show, and I'm going to have the thing, I'm not going to go through all these slides, where Benedict XVI says, palliative care centers offer the sick the human assistance and spiritual company they need. It's a right belonging to every person. The Holy Father's saying that. The point I was making about the ethical and religious directives before, which I didn't complete, was that, again, the New York Times and the Globe would make it seem like there were 3 lines: no abortion, no sterilization, no contraception. But their lines about effective relief of pain control is extraordinarily important. Using that line, I did a lot of work with Catholic hospitals, and so they started palliative care centers because I go, you don't think about tying tubes in the operating room here, do you? And if somebody did that, you'd quickly call the bishop's office and everyone would get nutty. But I can walk down the hall and there are people who are in pain because the doctors aren't attending to that. You're violating the ethical and religious directives. More important than violating a rule is you're violating our obligation to care for the least of our brothers and sisters and to treat them in the best way possible. It's important that we continue to make this progress so that a civilization of love cares for life even when it's fragile. It provides a variety of different care. It attends to pain and suffering. Now here's some of the other part about suffering. You know what? Dying's still hard. It's not a barrel of laughs. And the things I think of, at 56 are, I love to go fly fishing in Montana, but there's going to come a time I'm not going to be able to do that. And I have all these little babies who are the children of my medical students, and I got 2 little boys called Myles. And I love those relationships, and when the time goes that I'm going to be slipping from life, that's going to make me sad. And I'm pretty religious, you know. There's a plenty of things with stripping away the links that we have. And the other part is, you know, it's hard. It was hard for Mama to not have total control over every sphincter in her body. You know, but we get this crazy thing about dignity. My dad used to call her Queenie for Queen Elizabeth. And let's just say in Depends, she was every bit as imperial as she was when she was in her 40s, okay? So I think dignity doesn't have to do with whether or not you can get out of bed and control the world, or whether from time to time you end up wet. Dignity has to do with something because we're made in the image and likeness of God. And it's what we make of life as a gift from God that we can live responsibly. That's what we're talking about. Now, if this were not a Catholic audience, and the good people here think the Catholic stuff is a pile of hooey or they don't believe in God, I'd say here's the point. We're making tons of progress in how we treat the end of life. Here's the other part. People can kill themselves anyway. Let's not make it accepted as part of medical care so that the young doctors who I would spend lots of time teaching how to take care of people at end of life, and people when they're dying are not always sweetness and light. And their families can be a complete pain in the gluteus maximus from time to time. That's an anatomical term. It was not foul. It's a lot of trouble to do that. Wouldn't it be easier to say, I think you've suffered enough? I mean, there are plenty of times where I've said, you know, if assisted suicide was an option, I'd sign her right up. She's a pain, you know? And again, I think we have to admit that. Some people are extremely difficult. The other part is some illnesses are hard. And here's the thing, taking care of old people. Sometimes your family does a really good job of making you feel like a burden. And, you know, people would say, well, if you were an Eskimo, we'd put you on the ice floes. I go, oh, why don't you get on the ice floe? You know, again, there's this whole big thing that because you're old, your life isn't worthwhile. That's crap. Again, your life has as much intrinsic value as the life of anyone. Does it mean that it might be a difference in the intensity of medical care? Sure, we call that common sense. But that doesn't mean that you should take your life or be encouraged to take your life. The number of times patients would say, I want you to kill me, was very frequent. And what I found was often what they needed to have was a conversation about that I still valued them and cared for them. Those conversations weren't easy, and I actually taught a whole thing on what do you do when the patient asks you to kill him? You go, can you tell me why you feel that way? You must be very upset. Are you in pain? Haven't I paid attention to something? Did something go on at home? What's wrong? Often, it was more a cry that there was a problem not attended to. They were miserable, maybe not even depressed, but just existentially in a funk. If you go, well, I think that's a good idea, and you were take out your prescription pad, what's that going to say about how we care for people? This is a nutty thing. And guess what? I do think it's probably going to pass in Massachusetts. But that doesn't mean that it's over. That doesn't mean that it's over. Things didn't end on Good Friday, boys and girls, okay? We have the potential to show that we are the people who live by the cross and the resurrection. We value life. That we were created by God out of love and called to an eternity with Him. That we recognize that good medical care is an important part of the right to life. And that good medical care has to be attentive from conception to a natural death, with a natural death meaning an intelligent application of the treatments available, always trying to heal, realizing we can't always cure, never taking life, always caring. That's the things that we need to demand and push for. What would I say should be an alternative to the assisted suicide legislation? I'd argue for more training on end-of-life care, but in fact, in Massachusetts, you do need to get some credits to have your license renewed for end-of-life care. And the Mass Medical Society is against this particular legislation. But people are frightened. The big lie is out there. Life isn't worth living if you're not pretty and can't be on television. That's why I'm on television now. I don't know if you've seen me on Catholic TV with the Aging Gracefully series. I've been told I'm now the centerfold in the AARP magazine. But my point with this is to say, don't be discouraged, don't be afraid. As John Paul II said, don't be afraid. As Jesus said in the Gospel of Mark, fear is useless, what is needed is trust. What I've given to you is the good news of the gospel of life. Go on and spread it. go and vote on Tuesday, since maybe we'll beat it. But we haven't lost even if we lose that, okay? You people have the ability to change a culture. You have the love for your faith that too often is put in polemical terms as opposed to a love of the world in which we've grown up in which we love Christ and his church. We know priests and bishops are fallible like any other human being, and the most important thing is Jesus. That's what I'm talking about. And that's the thing that we can continue. And this provides us an opportunity, even if we don't get what we want on election day, to really be re-evangelized in our faith. Here's the thing that I often find with people in a real crisis. Do I know what to tell you with a 25-year-old in a horrible automobile accident? It's a tragedy. And for me to pontificate, stupid. Do I have an idea what to do with somebody who in their 80s and 90s has been sick for months and is failing and there's a crisis? Common sense. So John Paul II. So he died in April of 2005. He was in 82, 83 when he died. He'd had Parkinson's disease for a number of years. He still maintained a very public role, and in fact, one of the things initially to my shame, I can remember watching a Good Friday service when he was from the Colosseum and they were doing the Stations of the Cross. It was that portion where he drooled all the time. And he's there holding the cross in the light, and you just see all the drool coming down. I go, this is a hell of a thing for the Pope. And I go, what would young people think? And I go, this is exactly the image of Christ to show the world today. He is a man who still is a pretty impressive guy, and the drool doesn't take away from his dignity. So if they think less of him, well, people didn't think much of Christ when he was on his cross either. So he gave a wonderful example of how to live with a very serious illness. In January 2005, funny stuff happened, and he got a bad cold or bronchitis, and he ended up getting taken. You know what the joke is? You know what the best doctor is in Italy? American Airlines. No, but they took him to a hospital called the Gemelli, which is a very good hospital. And they did a small tracheostomy so he could breathe and put in a pediatric feeding tube through his nose, not through his stomach. Because he was so bent over, he had troubles with his windpipe and his swallowing as well as with the Parkinson's. Parkinson's medication is almost all oral. So for him, I guess, to be able to take his medicine, he needed the feeding tube. Now, they didn't put in a feeding tube in his stomach, which arguably would have been the adequate feeding tube. That's a whole other story. We're not going through all of that now. He comes back home, gets a little better, doesn't do all that well. And then finally in April, you know, the thing that he has a very serious urinary tract infection. He's septic, meaning that he has blood poisoning. That's what sepsis means. He dies in his bed at the Vatican in his own room. The Gemelli has a wonderful intensive care unit, and they saved his life after he was shot. They knew what to do. He didn't get the medications to keep your blood pressure up. He wasn't put on a breathing machine. They didn't do all the other sort of stuff. If the Holy Father gave us an example of how to live, maybe he gave us an example of how to die. And maybe that was one of his most precious last examples of preaching the gospel of life, that he was able to die at home and not hospitalized. And I used to say, they used to have Myles consults in the ICU where the doctors would call Myles, we have a terminally Catholic family up here, would you help? You don't have to be more Catholic than the Pope when it comes to end of life, okay? And so it's important to think about some of those things. So what are the things I'm saying? What do we need? We need improvements in care of the dying, but we're doing that. We don't want to cut it short. We need to talk about death and dying and remember this gospel of life and be able to spread this message so when people think, oh, Catholics want... This business about suffering. When I was 4 or 5 and I would scrape my knees, Nana would put Mercurico on my knees and I'd start to cry and she'd go, oh, offer it up. The idea that unite your suffering with Christ makes perfect sense. Before there was morphine, before there were effective pain medications, if you're in agony, what can be more effective way than to be able to ask Jesus to come into that suffering? If you have easy access to morphine, Jesus says, take it. Okay? Believe me, there's plenty of other ways to suffer, and the opportunity to be with Christ will be given to you as you face the end of life. We need to look at that stuff. Prudent advance directives. I think you should probably talk about, if you have more than 2 kids, you got to have if you have 2 kids, more than 1 kid, you got to have a fight at the end of life between the 2 kids. If you have a kid from whom you're estranged, they always are lawyers in California. And they come in at the last minute and they go to show mama how much he loves her by keeping her on the ventilator forever. Make sure that you talk to the doctor and that you get a healthcare proxy. In Massachusetts, that's the way that we do things. And with the healthcare proxy, you appoint somebody to speak with your own voice in the event of a serious illness, which you can no longer participate in the decision-making process. And what you tell your healthcare proxy is say, look, if it's a sudden illness, let them try for a couple days. But if it's not doing well, that's enough. Make sure I get the sacraments. That's okay. I've had a good life. I don't want to be kept alive forever. The thing for older people in particular to remember, though, is sudden acute illness in people who are doing well can be reversed. So I do like the idea of give them a day or two to find out. If it's somebody who's been declining for months, who's doing poorly, who has a lot of illnesses, I think you want to talk about a very comfort care measured approach. It's important, though, that the doctor has someone who can approach, who can speak with, and who can speak with your voice. To write this all out in statements, it's confusing. I remember someone showed up with a Catholic living will. And I go, I want to be treated in serious illness according to the tenets of the Catholic Church. And I go, I don't know what that means. I promise I won't do a tubal ligation on you when you're 90. I mean, I don't know what that means. So again, it's important that you speak to somebody who can speak with your own voice. As much as the parishes can to try to reach out, one of the things that some old people used to tell me is that I'd love it when the Eucharistic minister comes to the house, but it'd be nice if she'd sit down for 15 minutes and not run away. Are there ways in which we can end the isolation? There aren't enough priests to run around and do all this stuff, do all the home visits. There just aren't. But we can. The people of God can. It's your church. You can visit people, you can comfort the sick, you can do that. There was a Eucharistic minister my mother couldn't stand, and it was her greatest delight to tell me about how awful she was. I said, sounds like you really enjoy your visits. You get to store up a week's worth of venom after each one. I go, it's amazing Jesus doesn't jump out of your mouth when you get the host. She said, just because you're a priest doesn't mean I can't hit you, okay? But again, think about ways in which we can create that community. And then the other part is regardless. Or as some of my medical students used to say, irregardless, as I want to go like that. Regardless of what happens in the November election, push hard with Catholic health care to make sure that there's good palliative care, good hospice care. You need to fuss with the different chains. So stewards here, what do they do for palliative care services? What do you do for outpatient hospice? I would say that I'd like to say that every hospital in the state of Massachusetts, for every 150 beds, has to have one palliative care specialist. So if you got a 600-bed hospital, you'd have to have 4. If you have a 600-bed hospital, you've got to have about 50 cardiologists, okay? So what do we got to do to make sure some of those things can work out? There are ways in which we can make stuff better.
We want to thank Father Sheehan this evening for this excellent presentation.